So good afternoon, everyone. I'm Dr. Abha Siddiqui, advisor and mentor to the SRL Technical Center of Excellence and also academics. Today, it is my privilege to welcome you all to the CME on behalf of SRL Diagnostics. This week, as you all know, we are celebrating the Medical Lab Professionals Week. This is celebrated in the last week of April, and it serves to put the focus on lab professionals. The efforts and dedication that is put in by the lab professionals and the pivotal role that they play in the delivery of healthcare is often underestimated by the public and also within the healthcare community itself. So as we celebrate this Medical Lab Professionals Week, we also celebrate our own professional, bring public awareness to our profession, and also reach out to colleagues within the profession. At SRL, we have the tradition of conducting a CME during this week. And today, again, we are conducting a CME that is open not only to our SRL lab professionals, but also to colleagues outside SRL. The topics have been selected in such a way that they would be relevant to most laboratories and would be of interest to most laboratorians. For this, we have a panel of eminent speakers from SRL. They will be sharing their vast experience, covering the topic mainly in a case-based fashion, sharing the pitfalls, how to watch out for them, how to deal with them, and most importantly, how to interpret them in the clinical context. It is only if you have pathoclinical correlation that you can deliver the best lab report that enhances the image not just of the report, but also of the lab and the medical lab professionals. I would now request Chief Executive SRL, Mr. Anand K, to deliver the inaugural address. Mr. Anand has been a source of inspiration for all of us. And in fact, I would not be wrong to say that he's the motivating factor behind today's CME. Anand, sir.
Thank you, Dr. Abha. And good morning to every one of you. And wish you all a very happy Medical Lab Professionals Week. And we've all gathered here today to have a CME on this occasion, to commemorate this occasion. Before we begin, I would like to express my heartfelt thanks to each and every one of you for the dedication and service. What we have seen in the last 2 years has no doubt been challenging, and it gives me immense pleasure and satisfaction that we were able to serve patients seamlessly, even amidst the demanding circumstances. While it has been challenging, it has also been equally enriching, as the pandemic has packed a lifetime of learning for all of us in a short span of 2 years. As Dr. Abha mentioned, this has also put us in the forefront. So earlier, many people would never know what the lab functions are. But today we know that they all recognize the various aspects of lab. Not only the general public, but also within the medical community, we have received a very important recognition. And I'm sure this will help us not only in improving ourselves and putting us in the forefront of patient care, but also bring more talent into this industry, because we want more people to take up this profession, not only as laboratorians, as lab technicians, lab technologists, biochemists, microbiologists, pathologists. We see immense shortage of skills. Skilled professionals are not available at all. So we need more people to come in, and we want existing teams to ramp up their capabilities. So I think that is something which is a good thing that has happened because of the pandemic, and we need to capitalize on this opportunity of learning. Sometimes we are forced to learn, adapt, and grow, and it's important that we are ready for any learning opportunity as and when it presents itself. As you all know, our learning and development team curates regular learning sessions for all lab professionals. We do it on a rather weekly basis internally and on a quarterly basis outside SRL as well. So these are opportunities that no one should miss. Beyond this, learning comes from taking stock of how we perform each week and see what we could have done better. Regularly seeking feedback from seniors and peers is a great way to open up our learning prospects. In a laboratory, this is especially more important as it allows to improve our quality, efficiencies, level of patient care, and safety. Today, learning has been made so easy with the multitude of resources that are available and they are on demand online. So I urge every one of you to take some time off every week to keep up with the latest in your department, be it going through research material, journals, or research publications, or attending such MedGurukul conferences. These will allow you to stay on top by constantly upgrading and upskilling yourself. I also hope that all of you have enough time to write publications and journals. This is the ultimate validation of the work that you do. I also request all of you to reach out to the learning and development team if you have any specific training and learning requirements, and we will make sure to add that to our roster. Finally, I take this opportunity to thank Dr. Avinash Phatke, Dr. Chaitra, Dr. Srinivas, Dr. Arpita, and last but not least, Dr. Abha, for taking time off today to conduct this MedTalk session. And I thank you everyone for joining us today, and I look forward to a great session. Thank you very much.
Thank you. Thank you, sir.
Thank you, sir.
Thank you for your encouraging words. And we really do need the best brains in the laboratory. And as you said, maybe going forwards with the labs being in the forefront now, we will again attract the best brains into pathology. We will now begin the academic session, and I invite Dr. Avinash Phatke to deliver his talk. Dr. Phatke is President, Technology at SRL. He is also advisor to the Family Planning Association of India. He is advisor and mentor to the Association of Practicing Pathologists of India. He is vice chairman of Prince Ali Khan Hospital and a member of the steering committee of Aga Khan International. He is a recipient of numerous awards, including the Professional of the Year Award, Maharashtra, Healthcare Express, Distinguished Doctor Award, QCI Award for Professional Achievement, and also the Marathi Udyog Bhushan Award, amongst many others. Dr. Phatke would be presenting a medley of cases with a case-based approach to pathology investigations. Dr. Phatke, sir.
Thank you, Abha, and it's a pleasure to communicate with all of you during this midweek. And thank you, Anand, for introducing and speaking to us on this special occasion. Today's topic is slightly different than the usual presentation. It's not a set topic like autoimmune and then you discuss autoimmune panels. It is each case, what are the learnings from that case as we go along investigating it? Because when a patient comes for a blood test or a clinician sends something from hospital for investigations, it unfolds sometimes in an entirely different manner than we anticipate. So we will discuss few of such cases where at the end, we will have a summary as to what we learned from that particular case. Now, you look at this case one. This is a man who is 45-year-old. He has just come for a health checkup because there is a strong family history of premature cardiac issues and deaths in the family. So at the age of 45, even if he is not diabetic or hypertensive, he has come for health checkup. His lipids are absolutely normal, but because he has a family history, he was advised to do lipoprotein A. Lipoprotein A came high, so one risk factor. Then we advised him to do HS troponin I as a marker for risk stratification. And HS troponin I was high. This patient is now being treated with statins, even though his lipid profiles are absolutely normal. Now, all of us know that troponin I is used commonly for diagnosis of myocardial infarct. We have never heard of troponin I being used as one of the risk factors, just like your C-reactive protein, lipoprotein A, and lipid profiles. But there are enough papers, including in New England Journal and in Indian publications also, where a value of troponin I beyond cutoffs of 12 in male and 10 in females is a risk, just like your C-reactive or lipid disease. So because this patient had a strong family history, patient had lipoprotein A high, we also did his calcium score and it was found to be high. Currently, patient is on statins. So see, he is not hypertensive, he is not diabetic, but his lipoprotein A started the investigation journey. Because of strong family history, he has undergone all these tests. Otherwise, we wouldn't have tested normally for all this. Now, this is the paper, which is a research article published in 2021, an Indian publication, which says that the conscious treatment of use of high sensitive troponin I for risk stratification in apparently healthy individuals. So this is the particular patient, and this is the backup academics to show that it really works. So you can use troponin I as one of the risk stratification markers for cardiac risk. So current CVD, when you use HSCRP alone, it's very good marker. But many a times people have dental issues, people have mild GI upsets, and troponin comes falsely high. Many of us have autoimmune or allergies, and then HSCRP again comes high. So HSCRP, if you have no other comorbidity, it's a good marker. But in a day-to-day practice, many patients have some infective focus or another. So it's very difficult to use it as a specific cardiac marker, though it's very sensitive. But troponin I, that disadvantage is not there. So one can use it as a risk stratification marker for high-risk patients. It is not to be done routinely, just like lipid profile. Only if there is a family history or grossly abnormal lipids, high-risk patients, then you do troponin I. So the takeaway point are your troponin I and lipoprotein A are independent predictors or cardiac disease. For males, a value of 12 nanogram per liter, and for females, 10 nanogram per liter is considered high. If you do normal patients, it's below 1. Most of the time, it is either undetectable or 0.5 or 1. It never comes, the normal range is up to 30, but it never comes up to 30. It comes always below 1. So if somebody's is above 12, it is considered as a risk for cardiac events. Now, case number 2 is a very interesting case. He really, all the detective skills of the clinicians and pathologists were utilized during diagnosis of this case. And this is somebody whom I personally know. So it became all the more, the involvement was also personal apart from being professional. Now, this gentleman presented with cough, chest discomfort, fever of 102, hematuria. So we suspected he must be having TB because he was coughing a lot. There was hemoptysis and there was microscopic hematuria. We did his CT scan. It shows patchy opacities in both the lungs. So we were pretty sure we are dealing with tuberculosis with probably involvement of CNS because he had neurological signs and symptoms on MRI with small infarcts, or we thought we couldn't see any other lesion which will be causing all this. So we did his gene expert and sputum culture, and gene expert was negative. Sputum culture will of course take time. His cystoscopy was done, it didn't reveal any TB. So then we started working him up further, and then we did all other tests. His blood count was showing mild normocytic anemia, leukocytosis, and elevated inflammatory marker. So we knew it's either an autoimmune or an inflammatory condition. So because of the TB test coming negative, we went to autoimmune panel. Now his ANA came borderline, but his C ANCA is strongly positive. So he is a case of vasculitis. Cytoplasmic antineutrophil antibody directed against PR3 is very specific for generalized polyarthritis, polyangiitis, and that came strongly positive. P ANCA was negative. P ANCA is not commonly seen in cases of GPA. dsDNA is also negative. Now, all of you know that this granulomatosis with polyangiitis, what we call as GPA, was previously called as Wegener's granulomatosis. Now, we have stopped using the term Wegener's. I don't know how many of you know, but in 1980s, we realized that Wegener's was a member of Nazi party and he had participated in Nazi concentration camps. So we didn't feel it appropriate to name a major disease after such an individual. So that name was removed and now we call it granulomatosis with polyangiitis, though the clinical presentation is more or less similar. Now, when you do in GPA cases, always remember that C ANCA will be positive in 87%. But if you combine both immunofluorescence and ELISA, the sensitivity and specificity goes up from 87% to 96 and 98%. And this, if you see any medical textbook, they recommend that. Secondly, unfortunately, patients monitoring cannot be done on the basis of C ANCA. So you cannot say that after steroids or rituximab, this patient C ANCA is negative, so he is getting better. No. Or C ANCA is remaining, so he is not doing well. So the monitoring is mainly clinical and on the basis of C-reactive protein. There, C ANCA doesn't help you. Now, this patient, of course, was given steroids, and we have a wonderful new drug called rituximab, which is given IV every 6 months. Now, he responded to that. But then with immunosuppression, he again developed chest infection. Biofire panel detected pneumocystis carinii, and we had to put him on prophylaxis with Septran. So currently, he has been weaned off of steroids. He's on every 6 monthly dose of rituximab and prophylaxis with Septran. And surprisingly, he is doing reasonably well. Now, these particular cases before advent of rituximab, when they were treated with only steroids, they used to do poorly. I mean, the mortality was as 50-60%. Now, if you read the literature, the mortality has come down to less than 20%. So see a great mimic this disease is. Patient comes with fever, patient comes with hemoptysis and lung lesions, and it turns out to be not infective pathology or TB, it turns out to be a stormy autoimmune disease called GPA. Now, case 3 is your usual case. It is a case of diabetic nephropathy. His albumin creatinine ratio is high. You are increasingly seeing these patients. Most of them are on ARBs because ACE inhibitors are poorly tolerated. And now all the trials with glyphosines, first with canagliflozin, then with dapagliflozin, and empagliflozin trial, which came just about 4 weeks back, was stopped early because the protection offered was so great that the trial endpoints were met much earlier. So it was prematurely concluded, and empagliflozin is also now approved along with dapagliflozin for prevention of CKD and prevention of heart failure. So 2 different indications than for diabetes. They came originally as anti-diabetic drug, but now they are being used as drugs for heart failure and prevention of kidney progression. Now, when the patient was put on empagliflozin, his reports after 3 months showed the following. His urine sugar, of course, is 3+ because they cause glycosuria. Urine ketone is trace. Now, hemoglobin in these patients rises not because of hemo concentration, but there is some mechanism by which glyphosins increase erythropoietin levels. They can be measured in the blood. So this patient's hemoglobin went up by 1 gram. The creatinine, of course, went up from 1.1 to 1.3 because of reduction of intraglomerular pressure. And it's a hemodynamic change, doesn't indicate renal damage, and it gives long-term protection. After the initial rise, after 1 year, the fall in GFR from 2.8 in controlled diabetic patients per ml per year, in patients treated with empagliflozin, the fall in GFR becomes 1 ml per year. So at the end of the disease progression, patient gets at least 7 to 8 years extra before you end up with dialysis. So that's the advantage. So you must remember that you will increasingly see this type of urine pictures. You will increasingly see empagliflozin or glyphosine related changes in your biochemistry panels. And you will wonder that this patient has 4+ sugar and his blood sugar is normal. That patient is on empagliflozin or dapagliflozin. Now, we all know that these changes is expected. I have already discussed that the creatinine slope is initially increases, but the GFR loss is greatly reduced. And if I have mentioned Credence study. Credence is a study with canagliflozin, and DAPA is DAPA kidney study. But the empagliflozin trial is the last one, ended in 22, sometime in February of this year. So those all 3 trials have shown that adequate kidney protection is given. Now we come to case 4. Now see, this is a usual picture. Patient, a young girl coming to you with a thyroid swelling, very, very common. T3, T4 normal, TSH is borderline high. So patient was just given Eltroxin low dose, 15 mcg or 25 mcg, asked to do a follow-up test. Swelling was same. Now her TSH went down, but since the swelling was not changing, a USG guided biopsy, FNAC, and a USG of neck nodes and the ultrasound thyroid was advised. Now USG neck node shows enlarged lymph nodes. Serum thyroglobulin was raised. It was 120. FNAC showed papillary carcinoma. Now what is the purpose of showing this slide? Now if you ask any surgeon in Tata, or we are dealing with a new cancer hospital, so what we have seen that the incidence of papillary carcinomas in young girls has shot up more than 100% in last 5 years. So now you consider any young girl with a thyroid swelling needs to be fully investigated and not passed off as benign nodular goiter or benign goiter like we used to do when we were medical students. Because the incidence of thyroid carcinomas has gone up manifold. So you are seeing thyroidectomies being performed left and right. There are centers which in Tata Memorial, I talked to Dr. Prathamesh Pai and Dr. Chaukar. Their incidence of thyroid surgeries in last 3 years has gone up by 84%. So that's the importance of not ignoring this thyroid swellings and doing a full workup. So you should request a clinician that at least do a neck scan and a thyroglobulin. Don't just pass it or just don't do thyroid function and leave her alone with Eltroxin and just monitor. You have to investigate. So young patient with goiter don't increase because of the increased incidence of papillary carcinoma. Do the full workup. And as you know, these patients carry excellent prognosis if you operate early and if the focus is small. And even if the patient has metastatized to lymph node, they do extremely well. So it's important to pick up these carcinomas early in young females. I talked about females, they do occur in males, but females is more common. Now, case number 5 is again an interesting case. See what has happened. This patient has come for fatigue and tiredness. So usual workup for anemia was advised. And this is a girl coming from a rich family. hemoglobin 6.6, MCV low, RDW 19, we all know likely to be iron deficiency anemia. RBC count is low. Hemoglobin electrophoresis is normal. Ferritin is grossly low. So we started her on oral iron, repeated the CBC, and then there is no change after oral iron. And this is in spite of patient, we made sure that the patient is taking Orofer. So there was no instance that the treatment was not taken, but patient's response to oral iron was very poor, still low. Then patient was advised IV carboxymaltose. Now you all know that the dosage up to 500 micrograms can be given with 100 ml of saline, and you repeat the same after a week again. And then we started monitoring her and the hemoglobin increased rapidly. Now the question came that the girl is from a good family. She had taken oral iron. There was no nutritional deficiency which would have led to oral iron, iron deficiency anemia of this magnitude. So we started wondering that we are missing something in her. So test for malabsorption. Anti-TTG was of course positive. Anti-endomysial antibody was positive. Eventually, she underwent colonoscopy, confirmed case of celiac disease. Now, celiac disease patients will present many a times only with severe iron deficiency anemia. So when you see a young girl or a boy with severe iron deficiency anemia not responding to oral iron, that is the take-home message. Please ask for malabsorption syndrome tests, especially celiac disease. At least ask for anti-TTGA. Now we all know that when we use TTGA, you also have to do blood IgA levels because some people have IgA deficiency in whom TTG IgA is not picked up, and you have to rely then on anti-endomysial antibody. So when you are doing TTG IgA, always do blood IgA levels to rule out IgA deficiency. And finally, the case needs to be confirmed by biopsy. But even if you don't do biopsy, you have a clinical picture, TTG positive, endomysial antibody positive, then you are fairly certain you are dealing with celiac disease, and the cause of this iron deficiency anemia and not responding to oral iron was because of this. Now this case number 6 is a young couple. Now husband count, if you see, it's 25 million. So by WHO criteria, they are normal. Sperm motility was low, but sperm DNA fragmentation was high, 27. And the wife shows that the hormonal profile is normal. Already she is 35 years, and because she is 35, serum AMH was advised, it came borderline low. Now the optimum serum AMH value is above 4. 2.2 to 4 is satisfactory. So she is falling in satisfactory zone. With husband having low motility and sperm DNA fragmentation, which is high, you would advise them to straightway go for IVF or ICSI, because these patients don't do very well with IUI and waste a lot of 6-7 cycles with IUI, because with low AMH, you have ovarian reserve, which is not so high. And if you waste 2 or 3 years doing only conservative treatment or IUI, the eggs may not be available in sufficient quantities when a stimulation is done after 2 years. Now, I always ask this, that why do AMH? AMH is giving you an idea about the ovarian reserve. It is also predicting an onset of menopause, sometimes a premature menopause at the age of 40. A low AMH level always tells you that the ovarian reserve is poor. But a high AMH is commonly seen in polycystic ovarian disease because of a lot of granulosa cells being present in those follicles. So when I ask you a question that AMH, can it detect ovulation? No. Can it tell us about quality of eggs? Answer is no. Is it used for diagnosis of PCOD or PCOS? Because the AMH levels are high in PCOS. So is it a diagnosis for PCOS? The answer is no. It is only used to do number 3, that is to judge the ovarian reserve and fertility potential. That's the correct answer. This is our last case, which all of us see. Patient is mildly obese, elevated enzymes, especially SGOT, SGPT, alkaline is high, proteins are normal, bilirubin is normal. We do an ultrasound, we see a grade 2 fatty liver. The diagnosis is non-alcoholic fatty liver disease, but we want to know whether it's just a fatty liver or non-alcoholic steatohepatitis. Now, this is becoming very important. Today, out of 10 cases of cirrhosis, 7 are related to non-alcoholic steatohepatitis and not alcoholic cirrhosis. So why? The incidence of fatty liver in Indian population is more than 30%. Out of 30% who are positive, at least 5% will have steatohepatitis and not fatty liver alone. So imagine the percentage in population. Out of 100 people, 30 people have fatty liver, and out of them 5% will have steatohepatitis, almost 1.5 to 2%. 1.5 to 2% of our population is likely to have steatohepatitis or potential precursor to cirrhosis of liver. And this we are seeing increasingly as people are aging, we are seeing this. So again, like thyroid, the take-home message is don't pass off fatty livers as a benign condition and just leave it alone. Now this patient, what we did is whole workup for IgT, for diabetes, for insulin resistance, HOMA index, lipid abnormalities, hypothyroidism. Now, patient had a family history of cirrhosis. Because of that, he underwent a fibroscan, a liver biopsy. It showed that it was not non-alcoholic steatohepatitis, it was non-alcoholic steatohepatitis and not a simple fatty liver. Now, what do you treat? Most of the treatment is, all of us know, is lifestyle management, essentially weight reduction, taking care of lipids, taking care of sugar. Earlier, we used to try pioglitazone, we tried metformin. Now, there is a new drug called lipaglyn in India, which is saroglitazone, 4 mg, 1 daily, is approved by only Indian drug authorities for treatment of fatty liver. The phase 3 trials are going on abroad, but abroad this drug is not yet approved, but you will see many papers by Indian hepatologists. By use of saroglitazone, they have documented improvements in fibroscans. So there is at least some molecule apart from lifestyle management and vitamin E, which you can, attempt to minimize the progression to cirrhosis. And lastly, all elevated liver enzymes are, of course, not fatty liver. There are many other conditions all of us know, mainly drug-induced autoimmune hepatitis and so many other things. So I think all these cases have been interesting. Yes, it solves our, satisfies our professional instinct that you were able to work with a clinician and help the patient with appropriate diagnosis. But we must be also thankful to these patients because of them, each case is a learning experience for a pathologist if he is interacting with his clinician. So at the end of my talk, I would just request that none of this would have been possible if the dialogue was clinician was not continuous and ongoing in each of these cases. If you saw a case of GPA, if there was no dialogue with clinician, when he calls you up where your gene expert is negative and I am suspecting TB, patient has fever, you have to suggest that, we will do autoimmune panel, we will do the workup for P ANCA, C ANCA, things like that are going to help the patient and the clinician's faith in the pathology and pathologists would be enhanced greatly. Thank you for listening patiently.
Thank you, sir. Thank you for an excellent, insightful presentation. And these are, situations that we face on a daily basis. And if, as you said, if you just look at the figure and the lab result, it is meaningless. One needs to reach out to the clinician, correlate it, and that is what makes pathology interesting.
Yes.
Once we have the complete picture, then only will it become interesting. So there's some questions. The first question is regarding case number 1. And the question is regarding health checkups for adults. Should it be done and at what frequency, starting what age? Recently, there was a controversy in the media wherein the AIMS doctors and all said that it is not required unless there is an indication.
Yeah.
But you have highlighted a case which benefited from it. So what would your advice
So
be?
I would say those who are really high risk, I mean, there is a strong family history, or they're hypertensive, or they're diabetic, or their lipid abnormalities, either lipoprotein A or lipids are abnormal. In them, it is indicated. But I don't think it should be a part of routine preventive health checkup. So I think that answers your question. You can use it as preventive health checkup, but then you are going to alarm a lot of people when they have no other risk factor and value comes about, well, it's going to be really difficult situation, because nobody is sure whether they benefit with putting them on statins. They have no lipid abnormalities, just a troponin. So there are no clinical outcome trials. At the moment, we don't have clinical outcome trials to tell you that we should do it in each and every case, because, okay, troponin I high and we give moderate intensity atorvastatin and patients clinical outcome changes. Those kind of trials are not there yet. So though it is correlating with incidence of cardiac events, the prevention trials are not in place yet.
Yes. So only if there are risk factors and it is
then one
clinically mandated, then alone it should be done. So the second question is from Dr. Shalu, who's asking about the same case, like HS troponin is as an independent marker, but it is platform specific. So can HS troponin T also be used as an independent marker?
The papers are on troponin I. This work is unfortunately mainly done by Abbott. So unless you have a Abbott platform, I don't think you would be able to do it, because all the research publications are on, most of them are on that platform.
Right. The next question is from Dr. Jignesh. His question is high total testosterone along with high AMH diagnostic for PCOS?
No. See, in fact, if you see cases of PCOS, most of them don't have high total testosterone. What they have is high free testosterone. Total testosterone in those girls is always normal. AMH is high, but the diagnosis is, of course, essentially ultrasound diagnosis, a high insulin in 30% of the cases, other picture of impaired glucose tolerance, patient having hirsutism or signs of hirsutism because of high levels of free testosterone, and a borderline high prolactin. So all these constitute a syndrome called as polycystic ovarian disease. It's not a disease of ovary, it's a metabolic disease where hyperinsulinemia and metabolic syndrome overlaps. And many of these girls going forward will become diabetics later on in their lives. So it's not total testosterone or AMH which is diagnostic alone. It's the whole pattern of these tests, including the FSH-LH ratio, which are diagnostic.
Right. The next question is from Sandhya Fatke. Vitamin E is advised in fatty liver. How does it help to reduce fibrosis?
See, there are trials which show that it being an antioxidant, the amount of what it does, definitely it improves the liver enzymes. It doesn't improve the liver fibrosis to the same extent. So there is a biochemical improvement with vitamin E, but there is no reduction in fibrosis. That's why I mentioned that saroglitazar is the only molecule where there are documented Indian papers of reduction in fibrosis of liver. You can Google and see a lot of Indian articles on saroglitazar, but
Right.
not approved anywhere else in the world yet.
Is there side effects?
Mild weight gain, but unlike fibrates, so if you give finfibrate, they're nephrotoxic and causes rise in creatinine. These don't. It also helps in controlling the metabolic syndrome. So what it does is reduces triglycerides significantly, improves HbA1c, and improves liver fibrosis. So people are using it because you have nothing else to use in these patients.
And there is no significant side effect as such.
No significant side effect. I think up till now, the drug was introduced in India in 2010, and now we have 11 years experience. And I have discussed with Dr. Shashank Joshi, who uses it a lot and has 3 publications on saroglitazar. And the only issue is, again, no phase 4 trial, no clinical outcome studies done elsewhere apart from India, and the approvals are only in India.
India. Right. So there are no more questions on the chat. So thank you very much. Thank you for having taken time out, and thank you for your excellent presentation where you really taught us how to address a lab investigation. What begins as a lab investigation, you took us to therapeutics, you took us to follow-up, additional investigations, and made it totally comprehensive. Thank you once again.
Thank you, Dr. Abha. Thank you, everyone, for patiently listening.
We now move on to our second presentation, which is from Dr. Chaitra. Dr. Chaitra will be speaking on ABO blood group discrepancies. She is Technical Lead South and also Lab Head of Otis Nagar Bhave. Dr. Chaitra has 14 years of experience post-MD, 10 years in SRL. She has also done an MBA in Healthcare Services, is an NABH assessor, has authored many books on pathology and genetics for BSc Nursing, and has numerous publications to her credit. Dr. Chaitra.
Thank you, ma'am. Just share the screen. Good afternoon, everyone. Wishing all of you a very happy Lab Professionals Week. At the outset, I would like to thank the entire team of SRL and Med Gurukul, Dr. Abha ma'am, for giving me this opportunity to be a speaker today. My topic is, just give me a second. My topic today is the most basic investigation that is done in the laboratory, and that investigation is blood grouping. Whether we are a small lab or we are a big lab, all of us do blood grouping, and we know the procedure of blood grouping. All of us know about it, but then once we once we encounter one of such blood grouping discrepancies, it becomes a nightmare. And I'm sure all of us have gone through this, and we have our own stories to tell about how we tackled the blood group discrepancy in our labs. So what is this blood group discrepancy? Whenever there is a mismatch between the forward and the reverse grouping, that is when we call a blood group discrepancy. Like, for example, in this example here, if we see the forward grouping, we know it is O positive. So accordingly, we expect that there will be agglutination in the A as well as the B cells. But then here, there is no agglutination in the B cells. This classifies as a discrepant blood group. Blood group discrepancies can be because of technical discrepancy or clinical discrepancy. What comes under technical discrepancy? all the clerical errors, all our pre-analytical, analytical, and the post-analytical errors, which we talk about for blood grouping, are classified under technical discrepancy. And more or less, most of the times, whenever we end up initially with a discrepant blood group, this is the cause. So that includes the clerical errors, mix-up of the specimen, forgetting to wash the cells, preparing an incorrect cell suspension, failure to add the reagent or the sample, do not following the procedure properly, doing an incorrect centrifugation, incorrect interpretation, missing the identification of the blood specimen, contaminated reagents or using the reagent after expiry, using non-calibrated centrifuges, or using cell suspensions either too light or too heavy. So this is the most common reason why there is going to be a discrepant blood group. So whenever we encounter a discrepant blood group, we need to rule out all these causes first before going ahead and calling it that there's some clinical discrepancy. Now, what is a clinical discrepancy? Here, the problem lies within the patient. Basically, what happens is that the patient might either have a missing or an additional antigen, or the patient might have a missing or an additional antibody in the serum. Now, to solve such discrepancies, we need more information from starting from the patient's age, the diagnosis, the transfusion history, history of medication, history of pregnancy. So we have to go step by step when we have to solve such blood group discrepancies. The ABO blood group discrepancies are divided majorly into 4 groups, starting from group 1 to group 4. Group 1 discrepancy. Now, this is the most common discrepancy compared to the other groups, and it is seen mainly in the reverse grouping, and it is because of weak or missing antibody. The common conditions associated are in newborns. We know that newborns do not develop the blood group antigen until about 4 to 6 months of age. That's why we do not do a reverse grouping when we get a newborn sample for blood grouping. Elderly patients, their general ability to produce the antibodies and the proteins in the body is reduced, and hence they might also sometimes show a group 1 discrepancy. Patients with leukemia, lymphoma, immunosuppressive drugs, patients on immunodeficiency diseases, and patients with bone marrow transplantation might also have missing antibodies and might classify as a group 1. Now, how do we resolve this? For newborns, only the forward grouping is done till the age of 4 to 6 months. And the rest of the discrepancies can be solved by enhancing the serum grouping reaction. How do we do that? Now, that is achieved by incubating the cell serum mixture either at low temperature of 4 degrees for 15 to 30 minutes, or we prolong the incubation at room temperature for about half an hour to 1 hour and then look for agglutination. Most of the times, this would be the solution for group 1 discrepancies. Next, we have group 2 discrepancy. Here, it is because of missing or weak antigen. And this is least commonly seen type of blood group discrepancy. The causes would be because of subgroups of A and B in cases of leukemia and lymphoma, or where there are excess antigen of blood group soluble substances in the blood, or another phenomena called acquired A or B antigen. Now, there is this fancy term usually used called acquired B antigen. This is a very rare phenomena, but it is better that we all know what it is about. Usually occurs in patients with blood group A. These patients who have blood group A, if at all they have certain conditions of colonic obstruction, gram-negative sepsis, carcinoma, colon, such patients sometimes produce the bacteria D-acetylase. Now, before knowing what happens here, let us know the structure of the blood group antigens. We all know that the blood group antigens have a chain. This is the type 2 chain which is present on the RBC. And the A group antigen will have N-acetyl galactosamine as the terminal moiety. Whereas the B blood group antigen will have galactose as the terminal moiety. What happens in Acquired B is that the deacetylase enzyme, which is produced by the bacteria, will cleave the N-acetyl galactosamine of the blood group A antigen into a free acetyl group and into galactosamine, which is left as the terminal moiety on the blood group now. Now, this morphologically looks similar to that of the B group antigen. Now, this phenomena is what is called as acquired B. How do we resolve the blood group discrepancy under the group 2? Subgroups of A and B can be resolved by repeating the blood grouping using the washed red blood cells, use of anti-AB sera and the anti-A1 lectin, which are commercially available. For acquired B, we repeat the grouping by lowering the pH to 6, or we look at the auto-agglutination. The such patients who have acquired blood group B, they do not agglutinate their own red blood cells. So in vivo, there is no problem. Only in vitro, when we use the commercially available anti-B, is that it will show agglutination. Group 3 discrepancy is because of proteins or plasma abnormalities, and it is basically seen wherever plasma globulins are increased, like in cases of multiple myeloma, Waldenstrom's macroglobulinemia, post blood transfusion, post bone marrow transplantation, elevated levels of fibrinogen, which is usually seen in pregnancy, or use of plasma expanders such as dextran. Here what happens is that because of the increase in the plasma globulins, they tend to have an increased Role formation. Now we will have to differentiate whether whatever we are seeing is because of Role formation or is it true agglutination. To resolve that, we will have to wash the red cells about 6 to 8 times with normal saline, confirm it with microscopic examination. Most of the times, this will resolve the Role formation. If it still persists, then it is agglutination. That we can do for forward grouping. Now in reverse grouping, if at all we have to remove the effect of the globulins, then we perform something called as the saline replacement technique, wherein after incubation of the test serum and the RBCs, we centrifuge it for a minute. We remove the serum with the pipette and replace that serum with equal volume of saline. Then we centrifuge it for 15 seconds, resuspend the cell button gently and observe for agglutination. Now, once this is done, if there is no agglutination, then the initial thing what we saw was because of Role formation. If at the end still the agglutination is persisting, then it is true agglutination. We'll have to still investigate why the discrepancy is persisting. So that is how we look at the group 3 discrepancies and their resolution. The group 4 discrepancy is where there is polyagglutination. Like there are a lot of environmental stimulants which will produce a lot of alloantibodies within our blood, and some of them are incomplete antibodies, and some of them do react with the in vitro used anti-sera which we use, or they react with the A cells and the B cells in the reverse grouping, especially seen in cases of bacterial and viral infections. Patients with cold antibodies, so cold autoantibody and alloantibody, the identification of that will definitely pose a blood group discrepancy. I will deal with that in detail. Naturally occurring or irregular antibodies which react at room temperature may also cause a discrepant blood group. The resolution for group 4, look for history with symptoms suggestive of infection, look for auto control of the same patient's blood and the RBCs and the serum, and we'll have to do a direct antiglobulin test. Cold agglutinins, we have autoantibodies as well as alloantibodies. The cold alloantibodies are usually the IgM type, and usually seen with mycoplasma pneumonial infections or infectious mononucleosis. Now, the characteristics of cold agglutinin is that it is going to give you a ABO discrepancy. It is going to show a positive direct antiglobulin test when we use the anti-human globulin, which also has the C3. Like we get two types of anti-human globulin. One is a polyspecific, the other is a monospecific. The polyspecific anti-human globulin will have anti-IgG as well as C3. Now, this will give a positive reaction. Whereas the same anti-human globulin, which is monospecific if we use, that will give a negative result, which is a clue to say that it is a cold antibody we are dealing with. How do we resolve it? Use warm saline washes, pre-warm the sera and the reagent at 37 degree and perform the test, and that I have already discussed. Let's move on to case discussion. With this knowledge we have had about discrepancies, the first case is that of a 1-year-old female patient diagnosed as congenital diaphragmatic hernia for surgical procedure requesting blood. Now, once we do the blood grouping, this is what we got. The forward grouping looks like A positive, wherein we would expect no reaction with A cells and a 4+ or a 3+ reaction with the B cells in the reverse. But what happened was that we did get a 3+ in the reverse A cells. So now this qualifies as a blood group discrepancy. Whenever we come across such a case in the laboratory, how do we proceed? First things first, we have to look at all our technical discrepancies, rule them out first before looking at the clinical discrepancy. So starting from the TRF which is received, the labeling of the vacutainer, to the worksheets generation, the labeling on the either the gel card tube or the tube method what we have used, we'll have to recheck everything. We'll have to repeat the blood grouping by the tube methodology. Another person can do the blood grouping. Then take complete history of the patient, recheck all the reagents, recheck the centrifuge, recheck the procedure in which the blood grouping was done initially. If after all this still the discrepancy is persisting, take a repeat sample from the patient and redo the blood grouping. Even after all this, if still the discrepancy is persisting, then how do we proceed next? There are a few things which we can follow. Is that first we read the forward typing. Then we look for the strongest reaction. Usually the weak antibodies or the weak antigen tend to give weaker reactions. So that will point to say that there is something wrong in this particular area. That is where we'll have to look at. Then take complete history. And until the investigation of blood group discrepancy is completed, please do not release the report of blood group. If an urgent transfusion is needed, O negative red cells or AB plasma components can be used. The blood bank will definitely take a decision on this. Now coming back to our case, now we have ruled out all our technical discrepancies. We know now this is a clinical discrepancy. So it could be one of these things from whatever we have learned today. It could be either a A2 phenotype with anti-A1, it could be a cold reacting autoantibody or a cold reacting alloantibody. It could be pseudo agglutination due to the Roulet effect, or it could be an acquired B antigen. Whenever we look at a discrepancy where it is more glaring in the reverse grouping, we will have to have 3 sets of tubes, and we'll have to label each set of tubes as A, B, O, and keep one for auto control. Now, once you do that, add the serum and the red cells corresponding to the labeling you have done. One set, we will immediately spin that, and then we will examine for the blood grouping. The second set has to be incubated at 37 degrees for 10 minutes. Then you spin it, and then you examine the blood grouping in that. And the third set, you keep it for doing a direct antiglobulin test. So this is the thumb rule of solving discrepancy, where you see that reverse grouping is posing a problem, like what we had in our example here. So when we did that, this particular case still showed a 3+ in the immediate spin. The thing after incubation at 37 degrees was not seen. That means it is basically not a cold antibody we are looking at. So that leaves us only thinking about whether it is a subgroup of A. Use anti-A1 lectin, which is commercially available, where it showed agglutination. So this confirms that this particular patient has a A2 Rh phenotype, Rh positive phenotype with A1 antibodies. The second case is a 40-year-old lady with severe pain abdomen and HB of 5 gram per deciliter. The history was given that the patient had a transverse colon growth, which was reported as poorly differentiated adenocarcinoma. When we do the blood grouping, the forward looks A positive, B is having a 1+ reaction. Usually we know B has a 3+ or 4+ reaction. That is what we encounter in the regular practice. Let's see if the reverse grouping is matching. In the reverse grouping, the A and anti-A are matching. B is having a 4+ reaction. But here there is a 1+ in the forward grouping. That's why this qualifies as a blood group discrepancy. Let us try to investigate what has happened. As I already said, please rule out all the technical discrepancies before proceeding on to the clinical discrepancy. So there was a history that there was CA colon. And did we learn anything specific? Yes, we did that in group 2 discrepancy, GI obstruction, CA colon or gram-negative sepsis, we have something called as a acquired B in patients with blood group A. So we learned that there is an enzyme which is released, deacetylase, which will cleave the A blood group of N-acetyl galactosamine into galactosamine, which now resembles the galactose moiety of B antigen, and it starts looking like B antigen. So this does classify for an acquired B. Now, how do we resolve it, or how do we confirm whether it is an acquired B? One, we can check the past medical records in case the patient is a known group A. Check the diagnosis for bacterial infection with or without cancer of colon rectum. We did have that history. Third thing we can do is test the red cells with anti-B reagent acidified to pH of 6. At acidified pH, these antibody, there's going to be no agglutination in acquired B. Also, if we do the patient's own autocontrol, that will not agglutinate. So the final report for this patient was ARH positive with acquired B antigens. The third case is that of a 25-year-old male with backache. Now, this was the blood group that we saw. There is this kind of a reaction in the forward grouping of B. This is what we call as a mixed field reaction. This occurs because there are a lot of antibodies, and some of them agglutinate, some of them do not agglutinate, giving rise to this kind of a picture in our clinical setting. Again, after ruling out all our technical discrepancies, when we look for what could it be in terms of clinical discrepancy, we'll go back and take the history. The history of this patient revealed that this is a case of post-bone marrow transplant. So because there was a discrepancy, we can look at saline replacement method. We can wash the red blood cells and then look at the red blood cells after 6 to 8 washes to differentiate the roulet from true agglutination. Once that was done, this particular patient's blood group was confirmed that it is B positive. The mixed reaction was cleared. It became a clear B positive. So the final report of this patient was BRH positive. The fourth case is that of a 38-year-old lady for routine health check. Now, in this case, if we look at the forward grouping, it is looking like B positive. So we would expect the reverse grouping to have a 4+ in A cells and no reaction in the B cells. But what we got was a 1+ reaction in the B cells. And again, because I told that we'll have to look at the strongest reactions, because the weaker ones are the ones are going to tell us that the problem might be here. So this 1+ in reverse grouping in B cells look like this is the discrepant blood group. So again, when we are doing the reverse grouping, have these 3 sets of tubes, one for an immediate spin, one for incubating at 37 degree and then doing the spinning and looking for grouping, and the other for doing the antiglobulin test. Once that was done, this particular case revealed a 3+ with A cells and a 1+ with B cells, which disappeared in this particular set, which was incubated at 37 degrees centigrade. It gave a 2+ reaction to the anti-human globulin, which was using C3d as well as IgG. So this looked more classical of a cold antibody, hemolytic anemia, or that the presence of cold antibodies. Also, it was examined for rouleau formation, which was not present under microscope, and it looked more consistent with that of cold reactive antibody. So this particular patient blood group was reported as B Rh positive, and the reason we got a discrepant blood group was cold antibodies. These are my references. There is a very nice SOP kind of PPT PDF, which is available on the NACO website. I would suggest all of you to please go through it. It gives a step-by-step approach as to what we'll have to do when we are dealing with any discrepancy in the laboratory. Thank you one and all for your patient hearing. This is my team, and they are the heroes in lab coat at our lab. Thank you.
Thank you, Chaitra. That was excellent and very well highlighted by your cases. There is a question here from Dr. Arpita. In the case of acquired B antigen, is there any modification in clinical blood transfusion requirement? How is that dealt with?
Ma'am, in case of which this thing? Sorry, I couldn't
Acquired B.
Acquired B.
Adenocarcinoma colon case.
Yeah. They usually do well with blood group A. Actually, it is reversible once the condition, the enzymes are reduced, the deacetylase reduces because of the treatment. It is actually a reversible condition. All those which had started to look like B will disappear, and the patient's native blood group of A will come back again. So the transfusion is that of A only.
Right. If there are any more questions, you can put them on the chat or else raise your hand. Parasa, do you have any questions that have come to you?
No, ma'am. Yes, there is one question by Arijit Paul, that if reason is relox or cold agglutinin, then O cell also show positive reaction in reverse? Question mark.
I didn't get the question, Parasa.
Yeah, I'm just repeating that. I guess if reason is Rolex or cold agglutinin, then O cell also show positive reaction in reverse?
Dr. Chaitra, O cell.
O cell.
O cell.
O cell. O cell. O cell, usually we do not see much discrepancy with O cell, even with Role formation or with cold agglutinin. Cold agglutinin though definitely will not show, but then usually this 37 degree we'll have to bring it to find out what the blood group, but the Role formation will not affect the O cells.
Will not affect, right. So there are no more questions. Thank you, Chaitra. Thank you for your excellent presentation. We move on now to the next topic. The next topic is pre-analytical variables in hematology and avoidable incompetence. And for this, we have Dr. Arpita Roy. Arpita has been on this platform multiple times, and you are all familiar with her. She heads quality assurance and compliance in SRL. She also heads hematology at the Gurgaon Reference Lab. Arpita has close to 20 years of experience post-MD, having been in SRL for 16 years. She is an expert in hematopathology, coagulation, flow, quality assurance, and compliances. Also trained in flow cytometry at NCBS Bangalore. And today she will be taking us through pre-analytical variables in hematology. As you all know, with automation and technical advances, analytical errors have been minimized. And the main errors that we see now are in the pre-analytical phase or in the pre-analytical phase, as we call it. So I'll hand over now to Arpita, who will take us through this topic.
Thank you, Dr. Abha. Greetings to everybody for a Medical Lab Professionals Week. And I'm so happy to be on this platform and getting the opportunity to share my session with all of you. I will just share the screen just once. Is it visible?
Yes, yes.
Okay. Okay. So my topic of discussion today is pre-analytical variables in hematology, and I am calling it an avoidable incompetence, a very expensive one when it comes to it. And the worst part is most of the time we don't even know that pre-analytical variable is sitting right there in that sample, and that might lead to erroneous reporting, loss of faith in the lab, and might lead into medical legal circumstances also for the lab. So this is the burden of the pre-analytical unseen burden that we as laboratory people are sitting. And today, as we celebrate the Medical Lab Professional Week, I thought that the pre-analytical zone, which is the most the area with the most amount of erroneous result to be looked into. So when we looked at, like Dr. Abha just said, 70% or 72% of the total lab errors fall into the pre-analytical phase. 27% go into the post-analytical. And of course, as the analytical phase is controlled by most automation nowadays in laboratories with a spectrum of calibrators, quality control material, and robust quality control systems, of course, the analytical phase is the least with errors. And this comes with a study and also with some type of personal experience also, that when we look at the section-wise, I mean, the bread and butter, the main sections of the routine laboratory, a huge percentage of the errors sit in the hematology section. So the objectives of our talk today will be to identify the significant pre-analytical errors during blood collection, separation, and transport in a hematology laboratory. Of course, we will also take some account of the coagulation parameters too. Explain the various means of pre-analytical error prevention. So how do we go about it? Understand the to-do list and the critical effects of these pre-analytical issues in the sample. Recommend the steps to recognize and handle such samples. So most important is to recognize them, to pick them up. Remember, we are dealing with whole blood samples here and in the hematology segment, and picking up pre-analytical visually is more difficult in the whole blood sample than in a separated serum or plasma. And just some suggestions around robust QIPs and process improvement plans to focus on the pre-analytics. If I take you through the journey of the blood sample, the critical trio here sits into the three phases: pre-analytical, analytical, and post-analytical. All of us are aware of the big pre-analytical phase we have, including the patient preparation, sample collection technique, how well trained our phlebo is, whether he's maintaining the order of draw, whether he is picking up the sample, I mean, pricking and taking the sample as per the guidelines and the SOPs. Sample separation is a huge, very, very important part of this pre-analytical process, and further on the processing just before he transports the sample. And of course, sample transportation from the phlebo bench to the bench top on the lab table is a huge area of concern in the pre-analytical phase. Analytical, of course, is the assay testing, the actual testing on the instrument, along with the calibration quality control measures that are taken on the automated equipments. And post-analytical will encompass result transmission, sample storage as per post-testing sample storage as per retention policies. Any delayed reporting will come into the post-analytical form. Transcription errors, of course, all this belt goes into the post-analytical phase. So just to bring you a snapshot of the pre-analytical variables and the common errors here that might occur in a laboratory. So right now we are not focusing primarily on hematological laboratory. This is a general laboratory scene. So my pre-analytical variables, of course, there will be patient variables. Now patient variables on the diet, the body mass, the age, the medication, the gender, smoking, pregnancy, exercise. So all these, even geographical distribution from where the patient is coming from, the ethnic background of the patient, all these are the patient variables that might affect the sample results. Sample collection variables, lot of variables are seen in diurnal variations. Of course, less in hematology, more in biochemistry, diet collection, fasting status, how long or how tight is the tourniquet tied, if it is a hospital pickup, it's an IPD patient, presence of the IV, and picking up the sample from the IV side might add in dilution effect to the sample. Capillary versus venous, what type of sampling is being done. The collection variable only leading to hemolysis, clotting, lipemia, not doing a proper centrifugation, the processing time, like how long has the sample sat before it is actually being assayed on the bench. The temperature, exposure to sunlight, evaporation, aliquoting is a huge pre-analytical variable. Labeling, criminal to have a long misidentified or mislabeled sample, but that is something that we face in and out in our laboratories every day. And when we go into these errors, so major sources, of course, like test requisition. So erroneous requisitions, the TRFs not being filled properly, that is another area of concern. The patient identification we have already talked about. So these are all the things. Then the patient collection, so mislabeled, hemolysis, all these things add on to the pre-analytical errors. Sample storage, improper temperatures that the sample is being transported in, the length of time it is taken from there, freezing and thawing activities, multiple freezing and thawing activities, especially important in coagulation samples. So these are what are the major challenges. Now, if we specifically talk about hematology and we talk about a picture of diurnal variation, many of us might not be aware of the slight changes that diurnal variation takes in a CBC report also. So this is a paper which was published in 2011. It's a very nice paper by Sennels. So RBC hemoglobin and HCT decrease progressively from the day till midnight. So we are having our highest RBC hemoglobin and HCT counts in the morning, decreasing till midnight, and just the opposite with our TLC count, eosinophil, monocyte, and lymphocyte counts, that they increase progressively from the day till midnight. So towards midnight, they are on the highest. So this is one subtle situation or one subtle indication that how these small things during the collection is very important to note, that from where all these pre-analytical errors might arise from. Okay, so in a hematology laboratory, if I would like and present to you today what should be the absolute mandatory sample rejection criteria. So one is, of course, QNS, quantity not sufficient, we cannot do anything about it. That's a rejection criteria. We will have to take a resampling. Incorrect patient identification. If we know it, many times we will not be even able to know it before we churn out the result. But if we know it and catch hold of it, it is an absolute sample rejection for us. Contaminated specimen, broken and leaking tubes, all these are absolute rejection criteria. incorrectly labeled samples, incorrect specimen, of course, incorrect vacutainer has been picked up, coagulation sample has been picked up in a heparin vial. So all this is absolute rejection criteria. These are outright ones. And underfilled and overfilled tubes. Now, this is very, very important for all of us to remember that whether we are dealing with life is easier with these vacutainers, but remember that the blood versus the ratio is fixed, and there is a marking on these possibilities of either clotting into the sample in case we overfill it, and dilutional effects if we underfill it. And this is the order of the blood draw that needs to be maintained. All our phlebos are trained on this, and everybody in the laboratory should know that why this order of draw is there. And there is a reason why this is done, so as not to avoid any contamination. So blood culture comes first. We do not want any kind of contamination there. Then comes the citrate tube. Then comes the SST or the serum tube. Then comes the heparin tube. Then comes the EDTA tube and ACD or fluoride, if whatever this thing. But this is the series that a phlebo, anybody touching the, this is a Bible for anybody touching the patient to do a phlebotomy activity that he should be following. So if I go into specifications of the pre-analytical errors in hematology, so we just to look at literature review. So this is a very nice paper which was published in 2018 by P. Arun et al. And this is on a tertiary care hospital in south of India, seeing the OPD and IPD hematology pre-analytical errors. And if you see here, of course, we all know that clotted samples and hemolyzed samples should be our top two things that we see. And of course, misidentification and all that happens. But usually these are the top two things that we see in a hematology laboratory. Now, similar on this ground only, our experience at the Gurgaon Reference Lab in the hematology and coagulation section for our pre-analyticals identified errors. Now, remember that because we are dealing with whole blood samples, there will be some cases of minor hemolysis that are not caught visually. But those might not even affect the results. But this is our experience and our incidence percentages, showing again the hemolyzed sample and the clotted sample among the highest offenders. Now remember, hemolyzed sample with this heat in northern belt prevalent at present, we see a lot of, every summer we see this increase starting from March going up to June. So we see a lot of hemolyzed sample coming in this belt for the EDTA. So now we will specifically go into 2 or 3 of the main culprits in a hematology lab. The first one is around hemolysis. Now, what is hemolysis? It is, of course, the critical culprit in our laboratories, in our lab section in hematology. So what is happening? The RBCs are breaking. So what does it bring into and opens up into the plasma is hemoglobin, of course, and other components of the RBC like potassium, LDH, NSE, and all intracytoplasmic elements of the RBC are thrown into the plasma. Now, what does it do? It calls for us in the laboratory to handle these samples with care, first to recognize them, then understand ways to handle these samples and perform the corrective actions of interference. Now, when we talk about hemolysis, it is of primarily 2 types. We all are aware it is in vivo and in vitro hemolysis. Now, in vivo hemolytic samples basically might be, there will be multiple inherited or acquired conditions, clinical conditions that the patient is going through. Because of that, the in vivo hemolysis is happening. So like there might be defects in hemoglobin, there might be hemolytic anemias, there might be defect in the RBC membrane leading to this hemolysis, G6PD deficiency, pyruvate kinase deficiency, and RBC enzyme deficiencies. There might be conditions, clinical conditions like burns, severe infections, mechanical damage in the circulation, all these might lead to in vivo hemolysis. Now, in literature, less than 2% of the hemolyzed samples were detected in the clinical laboratory is shown to be due to in vivo process. And what happens if there is in vivo hemolyzed samples? It is, we need the patient's history. Of course, we need to go back to the patient, to go back to the clinician, find out the patient's history, knowing the patient's clinical situation, and communicating at the right time of the interferences to the clinician. The next type is the in vitro. Now, this is the area where the clinical labs plays a very, very important role in trying to reduce this. Now, this is in our hands, usually occurs either due to the operator dependent or device dependent errors. So in operator dependent, there will be handling of specimen might not be right, and transport of specimen might not be right. Sample device dependent will be storage of samples, how it is coming, whether it is coming at the right temperature, whether ice packs are being put, sample processing. So this is the air belt that is more relevant in the total hemolyzed sample, and this is in our control. And so a very interesting CAP survey had come up a few days back, in which they showed that they did a survey that showed that 2/3 of the participating laboratories, CAP laboratories, had less than 3% of hemolyzed sample, whereas there were some continents and some areas in which even up to 1/5 reported as high as 15% or more of hemolyzed samples. So understand the burden that the hemolysis is on a hematology laboratory. Now, what happens when hemolysis occurs? So what are the analytes that are interfered with? So if we look at the increased levels, if hemolysis occurs, mostly these biochemical parameters are the ones which are affected and which increase in the presence of hemolysis. We are seeing AST, LD, potassium, that is a big concern, urea, creat, magnesium, ALT, creatine kinase, iron, phosphorus. So all these are on the increased belt in case of hemolyzed samples. Now, what parameters that are decreasing? Again, GGT, albumin, bilirubin, chloride, sodium, glucose. When we talk specifically around hematology, it is RBC count, hematocrit, APTT might be on the lower side, and fibrinogen. And what causes hemolysis? Specifically for EDTA sample, what is exactly causing the in vitro? What are the chances that we get these in vitro hemolysis from? The tunicate tied too long and too tight. The blood tube is either vigorously mixed or shaken. So there are multiple, so if they are not gently shaken, they should be shaken gently 8 to 10 times of inversion, but many times they are vigorously shaken, and that leads to hemolysis. Poor phlebotomy techniques, of course, leads to hemolysis. Specimen transport conditions, the time taken, the temperature maintenance, especially in this huge heat that we are facing in the northern belt right now. So there might be device related things that we talked about. Specimen storage, again, over clenching of the fist. So this is a very small thing, but over clenching of the fist might lead to these hemolyzed samples. Needle size too small. So of course there is resistance there is friction there, and the cells break. Making, so a finger prick, if you milk too much from that side, there might be chances of hemolysis. Drawing the specimen before the alcohol dries. So if you clean that side and draw it much before the alcohol dries, that is also a source of hemolysis. Over centrifugation and frozen EDTA tube. So these are specific causes that are under a laboratory's control to reduce hemolysis. So these are the areas to work on if any lab is looking at high hemolysis in the EDTA samples and experiencing this effect. So now what are the indicators and how to deal with this? Now, so on a CBC, so remember that again, if we are talking about an EDTA sample, firstly, it's a whole blood sample. It's a red colored sample. To recognize hemolysis is quite difficult as compared to a serum sample. And Another thing that might contribute there is the presence of, if it's a jaundice patient and high bilirubin, it might also contribute to the look of an hemolysis in that patient. So what happens? So by definition, hemolysis is present if the free hemoglobin is greater than 0.3 grams per liter. So that is by the literature definition. So, and how does it affect your CBC results? Of course, since RBCs are broken, it will reduce the RBC count and the HCT. Hemoglobin and MCV remains the same. Of course, the free hemoglobin will increase if we measure it separately from the remnant plasma on the top. And the platelet counts may also be inaccurate in these cases due to RBC fragments, which might be counted by the analyzer as platelets. So increased platelet counts might be a fault here. Again, so icterus we already talked about is also additional challenge in these EDTA samples. Now, for biochemical analyzer, nowadays many analyzers come up with these serum indices. They have this HIT indexes built up into their forum, and so biochemistry analyzers are more or less sorted in this area. But hematology analyzer, as on date, have not adopted too well to perform this task. So it leaves it on to the hands of the laboratory people to recognize this hemolysis in these samples. And how do we do it? Firstly, one way is that let the EDTA sample stand for some time undisturbed in a rack and see what the color of the plasma. Now that at times might not be in a busy laboratory with a huge number of samples, that might not be practically feasible. So how do I review and understand from a CBC analyzer data? Suppose that sample has been run. What I will see is, of course, my RBC count and the hematocrit, as we talked about, will go down. Now, since my RBC count and HCT is going down, if you look at the formula of MCH and MCHC, they will be falsely elevated. Now, looking at an analyzer printout of a CBC sample, my technician and the staff and the laboratory people should be well trained to pick this indicator up and see that, okay, a picture like this, I need to go back to the sample and check whether there is hemolysis there. Another way, of course, is doing a delta check, which might not be available, might not be feasible at that point, any point of time. Again, there might not be patients who are coming back again and again very frequently for a CBC to do a delta check on. Another indicator, of course, if there are biochemical parameters that are being requested in that patient, if there is an LDH, if there is a potassium levels, those will be increased. So those might be indicative that I need to go back to the sample, EDTA sample, to check whether this is an hemolyzed case. Now, in these cases, a prompt notification to the clinician, to the practitioner of the situation is very important in order to discuss and judge whether a repeat sample, and also to understand the history of the patient, whether a repeat sample needs to be procured and whether that is going to help out or not. Now, so this is a very interesting paper that Peng et al. Had in 2020. This is in the Clinical Laboratory Annals. And this is a proposed workout of lyased or CBC samples that they proposed. Now, they took, as per their, they took quite a huge number of hemolyzed sample, and they took the cutoff of free hemoglobin, which is clinically relevant, as 1.4 grams per liter. So what they did in the workout, they said that a normal, so CBC request has come in. They're asking for 1 hour of standing time, undisturbed standing time of the sample. Of course, practically not feasible into our laboratories, but this is what they propose. So if there is a visual check, if there is no hemolysis at all, even if we give it 10 minutes, we will be able to see the plasma, especially in the cases where the CBC analyzer is picking up the indications for you. But they propose this, and then if there is no hemolysis, go ahead and report the results. If there is hemolysis, centrifuge it, take out the supernatant plasma, do a measure of the free hemoglobin there. If free hemoglobin less than 1.4, you can release the report. Clinically not significant, that was their cutoff. Free hemoglobin more than 1.4, they they actually suggested a revised formula for RBC and MCHC, which I have on the right hand side of the screen. So they suggested revised RBC count should be done. So hemolytic RBC count. So that means the whole hemolyzed sample RBC count, whatever the analyzer has given, multiplied by the hemolytic hemoglobin. I mean the whole blood hemoglobin plus whatever free hemoglobin has come out, divided by the hemolytic hemoglobin. This was their formula for revised RBC. And revised MCHC, similarly, they did hemolytic hemoglobin raised to the power of 2. So this is actually square. This should not 2 here. Divided by hemolytic hemoglobin plus free hemoglobin, the whole multiplied by the hemolytic HCT. So this was a formula that they suggested, that anything that is free hemoglobin more than 1.4, if I can get a revised sample after talking to the clinician is okay. And that should be the first approach. If not, this is the area that we can put this formula, manually do it and give out the report with a disclaimer saying that this was a live sample. So dealing with hemolysis, after that, we come to the next big culprit is the clotted sample. So why is my DTA sample clotted? Again, the reasons: inadequate mixing of the tubes, no mixing of the tubes. So the phlebo has taken the sample and has just, without mixing, just placed it on. So the anticoagulant has not mixed well with the whole blood. So there is clotting present. Use of expired blood collection tubes, inappropriate order of draw, prolonged venipuncture, overfilled samples. Of course, the blood to anticoagulant ratio is jeopardized there, and there is a tendency of clotting there. So how can clotted samples be prevented? Gently inverting each blood sample, especially the anticoagulated one, 8 to 10 times. Gently, remember, is the word, and not vigorously shaking them to allow adequate mixing of the blood. Mix blood immediately after collection. Let us build in a practice of mixing the moment the vacutina comes out. With one hand, you might have watched the phlebo. He just mixes it and then keeps it on the stand. Fill all the collection tubes to the fill line. So avoid any dilutional effect there. So again, all these pointers, how to prevent it. These are small things that this phlebo needs to be retrained on. And we know there's a lot of attrition we have on the phlebotomy belt as well as in the lab belt. So training and retraining is what we are looking at. And what are the analytes that are affected in the clotted specimen? Of course, in CBC, erroneous counts, WBC, RBC indices, decreased platelet counts, because these cells get stuck in these clots. And of course, the remnant EDTA blood will show low counts. There might be prolonged clotting times for PT, APTT, thrombin time, and pipe. Now, remember, in a coagulation belt, if it is a hospital-based lab, we are getting these citrated blood. If it is a standalone laboratory, platelet-poor plasma is being created at the collection point, and the platelet plasma is coming over. So now sample initially, which some phlebo or anybody has removed or has not identified, and done a platelet plasma from that, my values of PT, APTT, everything will be very low. So that is an indicator that I need to go back and check whether that clotted sample, I need a fresh sample, I need a repeat sample. I need to talk to the collection point and ask them how they have collected, separated, and transported. So again, indicators and way forward in cases of clot. So the good lab practices, of course, asks us to, even the CAP as well as the requirements of good lab practices and ISO 15189 asks us to physically check for clots, either visually or with pipette. Now, we might argue in a busy lab, again, dealing with 1,000 CBC samples, checking every sample with a visually or with a pipette might not be feasible. In that case, what is happening is, please make it a practice whenever we are running a CBC. If I see a bicytopenia or pancytopenia in a sample, the first thing I ask my tech is to go back to the sample, put a pipette in, check for a clot, and a clot might be even stuck on to the vacutainer. Small clot might be stuck onto the vacutainer cap. So when he removes that, decaps that, puts in this thing, ask him to check thoroughly on the sides and the cap also to check out for any clotting. Thankfully, most analyzers are now equipped with clot detectors, but of course they will pick up the bigger clots, and micro clots are very difficult to pick up in anticoagulated sample. Now, presence of a clot in EDTA, EDTA sample and fibrin clots in citrate sample or platelet poor plasma citrate sample is a mandatory sample rejection criteria. Do not try and report out from a clotted EDTA sample. Timely, and we have burned our fingers once or twice in the lab, and I'm sure many of us would have experienced that in our own laboratories. So be very, very careful. This is a big, big culprit that we need to take care of. Then timely identification of clotted sample, critical to avoid these erroneous reporting, as well as unnecessary reagent wastage by running the sample. So if I can see a clot visually, I don't even need to run it. Why run it, waste my resource, and then ask for a separate sample. Then Rbc agglutination. Now we will talk about this last part. Dr. Chetra dealt with cold agglutinates in the prospect of blood grouping. Now we will deal with cold agglutinates in a CBC. Now again, cold agglutination is a big challenge in a hematology laboratory. What happens here is the hemoglobin HCT check fails. So the analyzer will give you a hemoglobin HCT check fail alarm. The RBC counts will be low, MCV will be raised, and if these are the indications on a raw data of the instrument, I do a PS examination and I will see these agglutinate sitting. Now so this is how the samples with cold agglutinates will look like. There are these small micro clots that are sitting, agglutinate sitting, which is sticking onto the tube. If you turn and churn the sample, you will see all these sticking onto the tube. So this is how the cold agglutinate sample looks like. And how does, so I'll just show you a case where we dealt and how we deal with this. So this was a case of an 18-year-old in which you see there is an alarm. It is given of H&H check failed on the analyzer and showing macrocytosis. The RBC count is as low as 1.73, hemoglobin is 8, HCT is 19. So my hemoglobin HCT, which usually HCT is known as that alarm is set at 3 times the hemoglobin, is that alarm is set off here, and an MCV of 110. Because the RBCs are all agglutinated, of course, the instrument counts it as 1 and gives it an high hemoglobin, high MCV. So now what do I do? So once I see once my techs see this kind of a picture on the RBC indices, they know there's something wrong with the sample. They pick the sample up, check, and this is how the sample looks. Now what do? They incubate the sample at 37-degree temperature at least for 30 minutes, and once it's pre-warmed, they run the CBC again. Now this is the post-warming, post-incubation CBC. Now you see that alarm has gone off, although MCV is still at 105, but things are much better now. RBC count at 2.2, hemoglobin 8.5, HCT has increased to 23.3. So now what do I do? How do I report this sample? I report out these parameters after incubation, put in a advice for a DAT, talk to the clinician, tell him there are possibilities of a cold agglutinate here, and put in the disclaimer in the report. These have been corrected post incubation at 37 degrees centigrade. Advise DAT to the patient and inform the clinician. The third main culprit is of me lipemic EDTA. For again, this is a huge case of lipemia. If this is absolutely separated, so it is very, very clear. But if it's a whole blood sample and very less lipemia, it might not be, even to visual examination, it might not be very visually apparent to us. Or at times this kind of this thing, if I mix it up, it might, the color of the blood will be obviously pinkish and it will be lightened up. So now, why is my sample lipemic? Inadequate time of blood sampling after the meal. So post-meal immediate blood sampling has been done. Cases like parenteral administration of synthetic lipid emulsions, I can get back to the patient, find out the clinical picture of the patient from there. Neonatal samples, so on on breastfed samples and neonatal samples. Pathophysiological conditions like diabetes mellitus, multiple myeloma, acute pancreatitis. So all these cases might be the reasons why I have a lipemic EDTA sample. Again, whole blood samples, lipemia is one of the culprits that is usually overlooked or goes unrecognized. Overall frequency, 0.5 to 2.5%. In our lab, we see it in 0.05, 0.03% at some points. Now, how to detect lipemia? Firstly, of course, a visual detection. At least give a 10 minutes rest. If the color is looking a little different, gives it a 10 minutes standing rest. See how the plasma is looking at the top. Again, visual detection, very hard, can be observed at high concentration of triglycerides, more than 11.3 millimoles per liter. Of course, some biochemical analyzer, of course, come with this automated lipemia index, not very well standardized or available in the CBC analyzer. What are the analytes affected? Yes, so prothrombin time, because it is picked up by, especially by the instruments which use optic aggregometry as the methodology, grossly lipemic samples, PT will not be available to be, the instrument will not be able to give you a right report on that. CBC parameters. What happens is a falsely elevated hemoglobin value, because that lipemia is it is affecting the matrix of the whole blood sample. There is unwanted light scattering by the photometric methods when the CBC is being run. Now this blur is created in the hemoglobin wavelength, and that wise it affects the hemoglobin. It gives an erroneously high hemoglobin value. Now we get this quite often, and how we deal with it is, so how you deal with it is very much clear in the guidelines. Run the CBC sample, whole blood sample. So I have a lipemic sample today, run the CBC as such, whole blood sample. After running the CBC, suppose I have a hemoglobin of say 20 gram % has come. Now centrifuge that EDTA sample, remove the supernatant lipemic plasma. Now run that lipemic plasma as a sample in the manual mode on the CBC analyzer. You will see that lipemic plasma or supernatant will give you a hemoglobin value of say 3 gram %. Now, how do you report out the hemoglobin value to the patient? Subtract this lipemic exudate hemoglobin from the whole blood hemoglobin. So 20 minus 3, give it out as 17. Put the disclaimer, this was a lipemic sample and this is how this has been corrected. So this is how you deal with the lipemic. Now just a snapshot and the take homes from what all we did today. So these are the parameters, these are pre-analytical errors. What are the parameters? What is the recommendation? That clotted sample, no reading, or even if microclot, there will be decrease in all values in a CBC. And recommendation is to reject the sample outright. Hemolysis, how it is indicated, RBC and HCT go down. Of course, because RBCs are being degraded, it should lead to a sample rejection, of course, depending on to the extent of the hemolysis. Or you can get in touch with the clinician, talk to him, take the clinical history to understand whether this is an in vitro or in vivo kind of a situation. If there is hemoglobin MCH are raised in CBC, decision according to the patient's clinical status again. Lipemia, hemoglobin MCH go up. This is due to the photometric interference, due to the turbidity. We have clearly discussed that subtract the hemoglobin of the lipemic exudate from the whole blood hemoglobin CBC and report it out with the disclaimer. Whole agglutinins, this is how it looks. RBCs go down, MCB, MCHC go up. Samples to be incubated at 37 degrees and retested and reported out with a disclaimer again. Platelet aggregates, platelets will go down. WBCs might show a leukocytosis because these platelets together fall into the size zone of a WBC, might be erroneously picked up as WBC by the instrument. So what can be tested with the new sample. So if there is a tendency of huge platelet aggregation, of course, ask for a citrate sample, citrate tube from the patient, repeat sampling into a citrate, because citrate is a better anticoagulant in these kind of cases than EDTA, because EDTA interferences might cause this platelet aggregation. Now, this is my last slide. This is just to show you how we can build up robust quality indicators and how we can do this pre-analytical process improvement. So please, it is for hematology laboratory as well as any laboratory. Of course, we are picking up these pre-analytical areas for quality indicators. So quantitate them, put in a target against them, that this is where I am, this is where I would like to achieve, and relook at your QIPs again and rework on those QIPs, and you can keep on decreasing the target so that you reach near perfection. Of course, we will have these samples, so we can put in things like misidentification errors. We can look into transcription errors, what transcription errors are happening, how much is the percentage happening there, incorrect sampling errors, incorrect filling errors, underfilled and overfilled samples. Very, very important in a hematology laboratory. How the samples are being transported, whether the samples not received, not properly stored, not transported in the right temperature conditions, ice packs not there, gel packs not there, dry ice not there. Contaminated samples, that needs to be quantified. Hemolyzed and clotted samples, of course, needs to be quantified and built into the QI. And how do I build up a process improvement program? I develop a strategy first with a focus on targeting. So first do the measurables, see how big your problem is on the pre-analytical bench, then develop a plan to attack the most common errors. So if I have 10 errors I have picked up, pick up the top 3 and start addressing that as high-risk areas. So process your design and redesign your process according to these errors. Look into ISO 15189 pre-analytical requirements, look into guidelines and develop these comprehensive SOPs. Communication, education and training, very, very vital. Training and retraining, very, very vital in this area. Constant communication should go out to your clients, touch base with your phlebos, do the phlebo trainings, very, very regularly retrain them, target all the stakeholders, target the home collection boys, target the phlebotomists who are actually taking these samples to do a competency assessment as well as train them. Then we can employ technology, like we said, for biochemical analyzer. Now we have the HIL indices and delta checks built up into many of their softwares. That is yet to be standardized. We are really looking forward to hematology analyzer having more of this kind of a thing. But technology and software-based systems to recognize this, these pre-analytical things as a much welcome. And then continuous quality improvement programs, look and introduce things like QC, QMS, do lean things like define, measure, analyze, improve, control, 5S kind of things, do elaborate root cause analysis, so method improvement, and all these kind of things can help us to focus on the pre-analytical processes and address them. Thank you so much.
Thank you, Arpita. The topic was covered very comprehensively and you've given many practical tips. And the process improvement program that you have highlighted, that should be incorporated into every lab. And it should be one of the basics in the hematology lab functioning. We'll quickly go over the questions. Sandhya Bhatke has a question regarding, can we measure hemolysis index of hemolytic plasma? She has also asked, how do we measure free hemoglobin?
Yeah, So so in again, like I said, Dr. Sandhya, this is not very standardized in the hematology analyzer as of now. It's a wish list for us in hematology, working in hematology sections, to all the vendors and to all the people who are creating, who are making these instruments. It is there, quite well developed now in many middlewares as well as instrument softwares on the biochemical front. For free hemoglobin, like we said, we can do a plasma hemoglobin. We can just let the sample sit, take the plasma and do like we did for a lipemic sample, and the remnant plasma on the top, we can just do a hemoglobin run on that and have an estimate of the free hemoglobin. But to be very frank, in the labs today, the that is not the way we actually are doing. That is a guideline, that is a paper that was published, but usually it is a grossly hemolyzed sample. It is we do a resampling, and that is, or reach out to the clinician to understand whether there are any in vivo conditions leading to that hemolysis. But the frankly hemolyzed sample, of course, we look at because the RBC counts and all go down too much, we look at a resampling.
Right. Dr. Neeraj wants to know how at times we get pediatric samples collected overnight and stored in the refrigerator. What is to be done when these samples come for CBC?
So again, a visual check would be required. So if this sample is sitting at the refrigerator at 2 to 8, that is, I don't think that should be a problem once you run it in the morning. But a visual check, again, especially it's a neonatal sample. Remember, it's a hard to get sample and it is a precious sample. So, I mean, we should be giving the full respect to that sample and try and report out whatever. I don't think sitting until and unless it is frozen, I don't think sitting at 2 to 8 overnight with 24 hours is picked up. And even after that, even after 24 hours, we understand that we have sample stability studies done at the laboratories. The things that are more or less that go haywire after 24 hours are the indices. Of course, we know that my platelets can go haywire, my differentials can go haywire, but my hemoglobin, RBC count, and there are few parameters which are stable and reportable. But overnight, 2 to 8, I don't think that should be a problem.
Not really. Dr. Anita Karrani has a question. When the patient has been given a heparin load during CABG, can we run a CBC? Should we collect the sample in EDTA?
Okay, that's a good question. So CBC should kind of be avoided at that point of time when there has been a heparin load given to the patient, and it definitely should be avoided for some time. And again, when there is these IV lines and all that, it is very, very important to connect back and to understand the situation, understand from where the sample has been taken, how long has been the time difference between the bolus dose and the CBC parameter being picked up, and wait for some time before we take this up.
Right. There's another question from Dr. Sandhya. Any reference for subtracting value from original value for lipemic sample? Because hemoglobin measurement is by SLS method by autoanalyzer.
Right. So I will share there is a CAP guideline also on this, and I will share the reference on that. I forgot to put that in this thing, but I will definitely share the reference on that. We have written references on that.
Right. Dr. Anjali Vishwanath wants to know about lipemic sample reporting. To be explained again, please. Okay. Very briefly, Arpita. We are running short of time.
Yeah. So suppose I have a lipemic EDTA sample today and it is visually lipemic. So what I do, I just mix the sample, it's a whole blood sample, run a CBC like a normal patient. Run CBC, you have a hemoglobin value and the entire CBC value again. After that, centrifuge that sample, pick up the supernatant lipemic, the plasma which is lipemic, put it into another tube and run that as a CBC sample on the analyzer, of course, in the manual mode. Now, once you run that, you will also see there is a hemoglobin value that comes against that lipemic plasma. Subtract that hemoglobin value from the primary whole blood hemoglobin.
That should answer the question. Thank you, Arpita. Thank you for all the tips that you have given, and wishing everyone, good luck with pre-analytical errors and a greater focus on it in the days to come. We move now to the last topic for today, and taking this is Dr. C.N. Srinivas. Dr. Srinivas is VP Technical, Head of HLA and Transplant Immunology. He also heads the lab at Fortis Arcot Road, which is located in Chennai. Dr. Srinivas is a senior pathologist with close to 28 years of experience. He is an MD, DNB, FCAP, a very passionate pathologist who's an expert in lab medicine, total quality management, HLA, and transplant immunology. He has taken training in molecular diagnostics and HLA from the Michigan State University. He has numerous publications to his credit in international and national journals. Dr. Srinivas has been one of the pioneers in urine analysis by automation. And today his topic is interestingly termed the P or WO. So we are looking forward to hearing about the WO from Dr. Srinivas. I hand over now to Dr. Srinivas.
Thank you. And I would like to wish every laboratory professional a celebrations with their passions and their professions for delivering the healthcare system the best what they can. And happy laboratory week to all of us. And I think I should also thank the SRL Diagnostics entire team for making sure that the healthcare system is robust during the pandemic times. With this, let me share my PowerPoints with you. Okay, so yes, it's quite interesting to understand about the P and the O here. So I would have rather kept the name in this as Pati Patni or O, which was a super duper hit during the 1970s, where Sanjeev Kumar and Vidya Sinha had acted to their best. So here in our P refers to the urine, not Pati Patni, and O refers to that of the interferences itself. Now the interferences in the hematology, the interferences in the biochemistries and serologies have been well dealt with. But most of the time, urine, which is a liquid gold, gets a orphan treatment in the laboratory, and also the interferences are overlooked. So the interferences in the urine analysis is very important to know, and the interferences refers to what it occurs when a substance or a process falsely alters an assay result. So that's the difference, that's the definition for the interferences itself. So if you take the interferences in the clinical laboratory per se, why it matters a lot? Because it leads to discrepancies in the test results and can lead to patient harm itself. So knowledge about the interferences in every part of the assays should be understood. And my topic for today is about what are the interferences in the urine analysis itself. So the interferences can be divided into two, whether it is pre-examination or post-examination itself. So the interferences, what we are going to learn today will be a case-based learning, and it will be talking about the pre-examination and the examination interferences. Now, my request to all is that to treat the urine similar to that of the blood, because urine is a very important biofluid, which gives a total reflection of the kidney health as well as the metabolic health itself. And for every patient and every time, make sure that the urine gets its due credit. As in any of the laboratory testing process, the urine analysis also has got what we call as pre-analytical as well as analytical and post-analytical way. So whenever you have got a request from the physician, it gets onto the test request, get onto that of the specimen collection manual, the patient preparations are done, sample is collected, and it is documented, transported, and it comes to the analytical process. Analysis has been done, and it's been reported by clinical chemist or microbiologist or a pathologist, and it is given back to as a report to that of the physician itself. The entire process should happen within a span of about 3 to 4 hours. And we should also understand that the urine is also very sensitive to the time. Now, whenever we are asking for a suitable sample, we should understand what the pathologist requires and what the patients understand. And hence, we should always make sure the pictorial depiction should be available, appropriate places to depict what collection you require, and kindly explain to the patient what sample you require, whether it is a midstream sample or a terminal sample, because terminal samples are very important for cases which are suspected to be schistosomiasis itself. So let us go to the case 1 here. It is a 32-year-old male who was a pilot by profession. He submitted the sample for the urine routine and culture at a collection center. The urine tested positive for the leukocyte esterase, but was negative for the WBC in the urine. The urine tested positive for the blood, but negative for the RBC in the urine. The bacteria on the microscopic examination was puzzling, whether it fits into it or not. The question here is that when you do a dipsticks test for the leukocyte esterase and the blood, it is positive in this urine sample. But when we put the same sediment under the microscope, we don't see the WBC and the RBC. However, the bacteria is also puzzling, because when we are viewing this, you have bacteria, you have got leukocyte esterase positive, blood is positive, but I don't see RBC or the WBC in the urine at all. Will there be any discrepancies in this is the question. Yes, the question here is that why the WBC and the RBCs are missing in the urine sediment. Whenever there is a time delay of more than 4 hours, the RBCs do lyse and the WBCs also degranulate and may not be visible on our urine samples itself. So we have to have recollection and redos, and unnecessary treatment and financial losses may also happen. So what are the impact of the delayed sample transportation to that of the laboratory testing centers? Whenever you have got a delayed urine which we receive in the urine section department, say for example after 4 hours or 6 hours, most of the time what happens, the cast disappears. You'll not be able to see the cast, especially the hyaline cast. There will be lysis of the RBCs and the WBCs, so you will not be able to see at all. The RBCs are totally missing and WBCs are also missing. There will be altered chemical reactions, especially the pH may be altered. The bilirubin and the urobilinogen may be oxidized and may not be given positivity with the dipsticks. pH also changes, which adds on to the problem of bacterial growth and also increase in the deterioration of the crystals itself. The glucose value also decreases. So pre-analytically, we should understand that there are a lot of interferences, especially with that of the time. The trichomonas loses the motility and it becomes like a WBC. So we'll be reporting this as WBC rather than the trichomonas itself. The yeast develops a lot of pseudomycelia and you will be seeing a lot of pseudomycelias rather than the candida itself, and there'll be increase in the bacterial growth. The first case was brought to all of us to understand that time is very important. Now, suppose there is a delay in the timing, kindly preserve the urine samples in the fridge, or you can use preservatives like boric acid tubes itself. The second case is 23-year-old female who was tested positive for blood in the urine, and the fresh sample from the same patient resulted negative. The laboratory uses recycled containers for the urine collection. So this is a gist I am giving you, that a 22-year-old female was tested positive for blood in the urine, and the same day she also gave one more sample because the doctor questioned that she is not having menstruation, there is no contamination of the menstruation blood, but why she is having hematuria. So a fresh sample was collected from the same patient and the urine was negative. So let us ponder what are the causes for the false positive results and what is the role of the urine container in the urine analysis itself. Now we should understand that whenever the laboratory uses recycled containers, we should make sure that the recycled containers are free of detergents. They are also free from formalin and they are free from acids. Because whenever you have got detergents, alkalis or acid remnants, they give to a false positive blood test in the urine itself. So that's very, very important. So the causes for the false positive results in the blood strips are basically because of the contamination from the alkali, acid, or formalins itself. And why I'm telling formalin very clearly is that all the biopsies of the endoscopy of the cervix or the endometriums are usually sent in small containers which are similar to the urine containers. Those containers should not be reused from the histopathology. So we should avoid recycling of the containers which has been specifically designed for the histopathology. The containers which have been devised for the urine collection has to be verified for not only that of the dipsticks, but also for any of the fungi or bacteria or parasites. You might see some small form of parasites, and which under collection of every sample, we might see that you have got the bug. When you have a bug, we will be reporting that as a louse or a public louse, which might give into a lot of problems itself. Now, the role of the urine container is very important because never ever reuse the containers itself. When you're using the reusable containers, it is going to give you altered results. So that was again a case study to make sure that we don't use the recycled ones. And whenever we have containers, we have to verify them. Case number 3. A 34-year-old man gave a urine sample for a pre-employment checkup, and the sample was shipped to a central lab where it is tested negative for the drugs of abuse. Is it genuinely negative or the lab missed out on some of the critical pre-analytical steps is the question. Now, whenever a laboratory gets a request for testing the drug of abuse, now the drug of abuse may be cocaine, morphine, or any of the other 14 types of drug of abuse, one should make sure that the laboratory is being good enough to pick those samples for the drug of abuse itself. Now, with the history of the exposure to the drugs, how to confirm the presence of the drugs in the urine is the first question. The second question is that what are the pre-analytical steps a laboratory should take to release the safe reports, and name the false negative artifacts on the drug of the abuse itself. Now, whenever you have got a test for a drug of abuse, make sure that the collection is done with a person seeing the collection procedure itself. That means to say that it should be like an inspector sitting behind this person to see that there is no contamination of the saliva, no contamination of the water, or no contamination of any other external agents what has been put onto the container to give it to you for the testing itself. That is first point. The second point is that if you are going in for drug of abuse screening, we have to make sure that the toilet closets has got some amount of alkalis which can pick up any contaminations it has been done. That is the second point. The third point is that better to have a dry toilets so that you will be able to be assured that the urine is given in a place where it has been subjected for scrutiny to have a dry toilets itself. But most of the time it becomes that it will be an inspected collection rather than that of a dry toilets itself. So these things has to be taken into consideration when we are testing the urine for drug for abuse. Now, where are the condition where do you see drug of the abuse testing? Most of the military services or administrative offices, prisons, transportations, treasury, nuclear power plants, and large industrial companies may be coming to the laboratories for asking us whether we are doing the screening for the drug of abuse itself. If any of the drug of the screening testing we have to do, we should make sure that the urine collection is done in a better scrutiny. Now, what are the lab responsibilities for the pre-analytical variables? One is the collection site. The collection site should be having better facilities for collection, labeling, and shipping samples should be done with boric acid containing containers as a preservative, or you have to make sure that you are refrigerated. The chain of the custody, especially for the drug of abuse record, should be maintained properly, and it should not be tampered during the transit itself. The laboratory should be having receiving records to assure that the integrity of the samples are best matching with that of the primary containers itself. So I'll not go in detail because of the want of the time. So we'll just go to the next important one. Limitations or interferences in the chemical testing in the urine. Quite interesting to understand that when we are having the urine and we have a dipstick testing which happens, there are some limitations in the chemical testing itself. The most important culprit is the vitamin C. The vitamin C is being one of the most contaminants what we see in the urine analysis testing laboratory, because most of the people do take ascorbic acid or vitamin C tablets as a supplement or a multivitamin drug which they are taking, which is having ascorbic acid in it. The ascorbic acid affects the following analytes: the bilirubin, the glucose, and the nitrate. And I have given you the interference level of ascorbic acid itself. So what happens in the presence of vitamin C? You have false low or false negative response to bilirubin, glucose, nitrate, leukocytes, blood, and urobilinogen. So these tests will be flagged off as false negative, though you are having the presence of blood, leukocyte, nitrite in that urine sample. Now, these are the medications also which I have brought across, and common medications and interferences, which is a very important tabular column which we have to display at the urine analysis segment itself. The previous one shows you the bibliography for this, that is the error-free urine analysis advanced for medical lab professionals, is the one which gives you this tabular column, where you see the measurements starting from WBC, that is the leukocyte esterase, the bacteria, the WBC, the albumin, glucose, all are having interferences most of the time because of the presence of the vitamin C. So whenever you have got vitamin C, you might have false negative results in any of these measurements which has been listed on the left-hand side. False positive also you get because of some of the drugs, especially with that of the antihypertensive and as well as some antibiotics, you might have false positives also. Now, the ascorbic acid has the ability to prevent the oxidization of the indicator substance in the urine strips. I have given you only one example, but this is what is happening. The ascorbic acid has ability to prevent oxidation of the indicator substances in the urine test strips, which alters the values of the bilirubin, urobilinogen, and glucose. Now, the discrepancy in the urine dipsticks analysis may also happen because of various reasons. Whenever you have got altered specificity. So whenever you have got altered specificity, again, you will have a discordant results itself. Whenever the patient is having a high acidic pH, again, you see that there is discrepancies in that. Now, coming to the false negative readings on blood. So whenever you have got false negative readings on the blood, it's not only the vitamin C, but also a low pH. A pH of less than 5 will give you negativity, false negative reports on the blood strips test. So not only the vitamin C, but also low pH value gives you a false negative readings. Now, this is one of the example here. The RBCs here in the sediment is positive, whereas the pH is 5 in this case, and the blood is negative. So the blood has been flagged off as negative in this, and this is one of the automated machines which are being used in the laboratories to show you that the RBCs are positive, but the pH is 5, and hence the blood is negative on the dipsticks. Bilirubin is also an interference. Whenever you have got cases like liver failure, cirrhosis, where the bilirubin in the blood sample is very high, they do interfere with the blood chemistry analysis. So bilirubin here in this case is 2 with a glycosuria, but again you see that the blood is negative in the chemistries, whereas the RBCs are plenty in that of your sediment analysis itself. So we should understand that the bilirubin also interferes with that of the blood testing to be given as false negative. The other negativity is because of the myoglobin. Myoglobin will be positive in your blood strips. Okay, myoglobin will be positive in dipsticks, whereas the RBCs will be negative, because the myoglobin also is a derivative of peroxidase group, and whenever you have got a peroxidase group, they give false positivity in your dipsticks, but maybe negative in this. So whenever we have a confusion of whether it is a hematuria or a myoglobinuria, we require to do that of alkaline saturation and do a spin. And when the supernatant is clear, it becomes myoglobin. If the supernatant is not clear, it is reddish, it becomes hemoglobin. So one more thing we should understand is whenever the urine is opaque, like chyluria, or if the urine is very much having hematuria with a lot of blood in it, and the viscosity and the opacity is very high, the dipsticks test will be not coming properly at all. You will be getting totally blank results. At that time, we recommend to do a spin and make sure that you remove the supernatants if it's possible, and do a dipstick with the supernatant and then proceed ahead. Now this again, I have got to understand to give you an information that the semen, the menstrual blood, the myoglobin and strip, which are submerged too long, vaginal discharges, and also the biological fluids interfere with that of the proteinurias as well as the occult blood, which one has to understand. So we have to understand that the piece, that is, we have now one of the piece to be this, one of the piece is this, one of the piece is this, one of the pieces. What I want to get you to understand is that whenever we have got urine, urine has to be submitted as every specimen to that of exact time, and you should engage the people to make sure that they process the sample properly. We should have good expertise at the technical bench as well as good equipment. A simple good centrifuge, a microscope, a dipstick, or a semi-automated chemistry equipment is good enough for the urine strip analysis to bring in a revolution in the urine analysis itself. Every sample, when you are engaging in a process, the people, and you have an envision and envisage to give you an enriched report, it's possible to deliver without hindrances our urine analysis report to our patients. Thank you very much.
Thank you, Dr. Srinivas.
Thank you, ma'am.
Questions, you could put them on the chat, please. Dr. Srinivas has highlighted, most healthy began his talk with how urine should also be treated like blood. And that is for me, that is a take-home message, because it's really relegated, put into a corner, dealt with when all the rest of the work is done. I see a question here. Can you please show second last slide?
Second last slide. Just give me a time. Second last slide. Is this the one?
No, we can't see your screen as yet, Dr. Srinivas.
Sorry, ma'am, sorry. Is it visible now?
Yes, yes.
Okay, I'll go to the slide which they wanted. Is this the one?
Is this the slide?
You can raise your hand or.
Yes, sir.
Slide 25.
That's the response. Yes, sir. Thanks.
Okay.
So this is a slide on the different interfering effect of different urine components.
Yeah.
Very important slide. And even otherwise, the session is being recorded, and for SRL people, it would be uploaded on SRL Med Gurukul. So you can go over the presentation yet again. I do not see any more questions. I do not see any more questions. So thank you very much, Dr. Srinivas.
Thank you, ma'am.
I would also like to thank all our other speakers who have made this CME so successful, and all the people who have logged in. Thank you very much for having joined in on SRL CME. and wishing you all once again a very happy Medical Lab Professionals Week. And let's take the messages that from today's CME forward. It is learning is our strength. In the end, as medical lab professionals, we have to stick together. We have to hold such CMEs. We have to learn, unlearn, learn from one another, and let's keep the process going. Would anyone like to say anything? We could unmute you. No. Dr. Srinivas, anything from your side?
Nothing, ma'am. I think what you said, the phrases were very interesting. Learn, unlearn, and relearn, which you have been put onto our gray cells. And age is not a factor at all. And diversity has to be accepted. Change has to be accepted. And the pandemic has made us to understand these in a very different way. So I wish everyone that we adapt to the scenarios, adapt to that of the multitasking, as well as move ahead with learning process, because that's the only way we can educate ourselves and give a good information to whatever samples we get to our patients itself. Ultimately, patients are our God, so we have to serve them.
Absolutely. Very well put. Very well put. So with that, we will conclude today's session. Thank you.
Thank you, ma'am. Thank you. Thank you.